Coronary artery disease is a condition in which one or more of the coronary arteries become narrowed so that the heart muscle does not receive enough oxygen. This is due to a slow buildup of cholesterol, calcium, and other substances within the artery's inner lining. This blockage is called plaque. Blood clots may form on the plaque, causing the artery to narrow even faster. St. Mary's Regional Cardiac Care Center has a cardiac catheterization lab equipped with 2 state-of-the-art machines for diagnostic testing by cardiac catheterization and coronary intervention with angioplasty. Patients in need of emergency coronary intervention have access to this service on a 24-hour, 7-day-a-week basis. Cardiac catheterization is a medical test in which the heart doctor, known as the cardiologist, puts a long, narrow tube called a catheter into an artery in your upper thigh near the groin or arm and is guided into your heart. Special X-ray dye is then injected, which allows your doctor to see if you have any arteries blocked in your heart on an X-ray monitor screen. This also helps the doctor to look at how well your heart and heart valves work. It is very important that you understand what will happen and what you need to do to prepare for your procedure. Cardiac Catheterization Department. This department is specially designed for your medical test. You will lie down on a special table. Around you will be an X-ray machine, TV screens, a computer, and a heart monitor. The room will feel cold, but this is needed to protect the equipment. What happens the day of your test? Take a shower or bath the night before or morning of your test. Do not eat or drink for 4 hours before your test. Bring with you all prescription medication in their original containers. Bring your health card. Wear loose clothing. Do not bring valuables to the hospital. Leave your jewelry or any large amounts of money at home. Take your pills with a sip of water. However, there is some medications that need to be held before the procedure. Stop metformin, which is a diabetic medication, 12 hours before and 48 hours after your procedure. Stop Coumadin, which is warfarin, 5 days prior to your procedure. Stop dabigatran or Pradex 2 days prior to your procedure. Continue taking your aspirin and Plavix, which is also called clopidogrel, or prasugrel, or ticagrelor. Please bring with you your reading glasses or contact lenses and case, your dentures, your hearing aids, the number and name of a responsible adult who will drive you home if you are scheduled for same-day discharge, a book or magazine to read while you are waiting for your test. What will happen during the test? The cardiologist doing the test will explain the procedure to you. You will have to sign a consent form to agree to the medical test. A nurse will start an intravenous in your arm. The insertion site, which is the area over the blood vessel where the tube will be inserted on your arm or groin, will be shaved and then cleansed with an antiseptic solution to prevent infection. It will feel cold, may sting a bit, but should not hurt. Most of your body will be covered with sterile sheets. The nurse will tell you where to best place your hands. It is important for you not to touch the sheet or move. If you must move, you should ask the nurse first if it is all right to reposition yourself slightly. The doctor will freeze your arm or groin. The needle may feel like a sting, and then this area will feel numb. At times, you will be asked to take a deep breath and hold it for a few seconds. This helps to get a clear picture. You will probably hear the camera take pictures. You may be asked to cough several times after the picture is taken. This helps to move the contrast dye out of the heart.
I'm Dr. Brian McNamara, Cardiology at St. Mary's General Hospital. This brief discussion is about cardiac catheterization. First, a couple of definitions. Cardiac cath, as the jargon word, is a study of the vessels of the arteries of the heart. It also involves looking at the valvular structures of the heart. Other terms for this procedure are coronary arteriography and coronary angiography. The kinds of patients who have coronary angiography or cardiac cath are varied. Most commonly, it's used to define the extent and location of blockages in the arteries that supply the heart muscle with blood. Other reasons include studying pressures and other what are called hemodynamic measurements of cardiac performance, and also looking at valvular structures of the heart. The test itself is very much like a chest X-ray, with which you're all familiar. There are several important differences, however. First of all, you're lying down on your back instead of standing up, and you'll be lying on a narrow table. Secondly, instead of a large square film, we actually take digital movies of the heart moving. Thirdly, the cameras move all around you, the patient, rather than you turning one way or the other. And of course, the biggest difference is that we have to access your arteries and circulation. The two places which we most commonly access the circulation are the femoral artery in the right groin and also in the right wrist. Once the anesthetic is placed, then we place a small tube in either of these sites to access the circulation to allow us to bring tubes up to the heart. There are other locations where we can get to the heart in case of obstruction or other technical features, but these are by far the most common locations that we use. Your cardiologist will discuss with you the best access site for your particular case. The procedure itself is done under local anesthetic. Once the anesthetic is in place, a small puncture is made in the artery and a tiny tube called a sheath is put in that allows us to change various shaped tubes that properly fit the vessels of the heart. Once the local anesthetic is installed and the sheath is placed, it's usually only 15 minutes or so before all the images are acquired. The results of the test are the most important aspect of this test. The results fall into several categories. The first and most favorable, of course, is that we find no significant blockage, and this is what we wish, of course, for all our patients. Unfortunately, that's not always the case, and the remainder of the findings are usually different degrees of blockages in the coronary arteries. The first finding is that we find blockage that's relatively mild, that we can manage safely with medication. The next level would be a focal narrowing in one or two spots that's favorable to be treated with balloon and stents or percutaneous intervention, and there'll be a follow-up discussion regarding this shortly. The last finding would be considered multivessel disease, where we have blockages in multiple locations in the arteries, and the best therapy is coronary artery bypass surgery. Frequently, we have a discussion at the bedside after the procedure with the patient and the family, and we put a plan in place. There are several populations of patients who might be considered for cardiac catheterization. The first group of patients are those who've had a heart attack or a suspected heart attack or suspected blockages in the coronary arteries without a heart attack. It's important for us to define the extent and location of these blockages so that the optimum therapy can be selected for the patient. There are other patients, for example, patients with valve disease who are going on to have valve surgery. We often study the coronary arteries of these patients to ensure there's no blockage before they go on and have valve surgery that would be a surprise to us later on. Most commonly, the patients with suspected blocked arteries are studied in response to symptoms that they may have had or investigations that they've had before coming to St. Mary's, such as stress testing with abnormal results. Like all procedures and medication, cardiac catheterization has risks and complications associated with it. There are minor risks and major risks. Generally, we don't do procedures on patients, such as cardiac catheterization, unless the risk-benefit ratio of the procedure is favorable. Certainly, we'd like to have a procedure have tangible and extensive benefits for the patient relative to the risks that the procedure might involve. The most common risks and complications are those related to vascular access. Most patients get a bit of bleeding or bruising at the puncture site, and very rarely we see a bleeding complication that requires a small operation to fix. This is extremely rare. Other complications include allergy to the dye that we use and effects of the dye on the kidney, which can be unfavorable. In addition, because we're in the patient's circulation, although only for a brief time, there is a small risk of stroke. Other complications include cardiac arrhythmias, either too fast or too slow, which are usually self-limiting but sometimes require intervention or drugs or even shocks to the heart to reverse. This is also extremely rare. Sometimes the patient can feel a bit of discomfort in the leg while the procedure is in progress as well. Major complications are very rare indeed and are only around 1 to 2%. There are alternative ways of studying the coronary arteries. Unfortunately, none of them are as specific and as accurate as cardiac catheterization, and none of them provide the means of going on and having percutaneous intervention or balloon stent procedures afterwards. Conventional stress testing is less accurate, and nuclear perfusion stress testing has a role to play, but generally patients who have high-risk findings on these types of stress testing go on and have the invasive studies with cardiac catheterization. There really is no substitute for cardiac catheterization in terms of the accuracy and providing therapeutic options for the patient at the same setting. Percutaneous intervention is a technique to relieve the obstruction in the coronary arteries. It's done in a similar fashion to cardiac catheterization and is also commonly done after cardiac catheterization after the same sitting. It involves not just shooting dye down the arteries like we do for cardiac catheterization, but it involves running a fine wire through the artery past the obstruction into the distal portions of the coronary arteries. Over this wire, certain equipment is delivered. Balloons wrapped with mesh coil stents are delivered to the site, and the balloons are blown up and the obstruction is relieved. Percutaneous intervention is the term used for a collection of technologies that are used to open up blocked arteries in the cardiac catheterization laboratory. Other adjunctive technologies are also used. Sometimes we use intravascular ultrasound, which is again a tiny ultrasound probe delivered over the wire, and also we sometimes measure pressures with special equipment to decide whether the artery is truly blocked up and requires treatment. Oftentimes when we're doing a procedure such as percutaneous intervention, we have to inflate a balloon in the artery and there's a temporary blockage of flow. Sometimes patients feel chest pain or angina while we're working on the coronary arteries in the laboratory. Generally, we get a nice angiographic result with relief of the obstruction during this procedure. There are complications associated with percutaneous intervention. The complications of cardiac catheterization discussed in the previous video are the same as those for percutaneous intervention, but there are some additional risks. Because we are working in the circulation for a longer period of time, and we use powerful blood thinners typically during this procedure, the bleeding risks are slightly higher. In addition, because we're not just shooting dye down the arteries, we're actually running wires and other types of equipment through the arteries, we can disturb the artery. This often requires that we spend a little extra time to get the nice angiographic result we want. On very rare occasions, we're unable to have the artery behave the way we want with relief of the obstruction, and we have to spend extra efforts to try and achieve a favorable result at the site. On very rare occasions, the artery simply will not behave and we cannot get the artery open the way we like, and we sometimes have to send the patients for emergency coronary artery bypass surgery. This indeed is a very rare event, but it is a risk nonetheless. St. Mary's will mail a booklet to your home to help you better understand what to expect before, during, and after your angioplasty.
What about the results? While the procedure is being done, the cardiologist viewing the video screen is able to get a preliminary idea of what the condition of your arteries are. Generally, the cardiologist is focusing on the procedure and will wait until after the test to review these results. The cardiologist will discuss your treatment plan. If the results of your cardiac catheterization suggest that further treatment or testing is required, you may be admitted to St. Mary's General Hospital. When it is done, the recovery period. You will be moved to the recovery area where you will stay in bed for several hours and may have to lie flat with your head flat or your arm raised on a pillow. The small sheath will be removed and a special clamp to hold pressure on your groin or arm will be applied to stop any bleeding. Pressure will be held for about 15 minutes. You will be told not to bend your arm or knee, raise your leg or cross your ankles, but you may wiggle your toes or your fingers. It is important during this time not to bend, strain, or lift. If you need to cough or sneeze, place slight pressure with your fingers over the groin site. The nurse will show you how to do this. Your vital signs and the insertion site will be checked frequently by the nurse. You should notify the nurse if your arm or leg feels cold, numb, or painful. If at any time between checks you notice warm or wet sensation at your insertion site or see blood on your bandage, apply pressure to the insertion site and call the nurse immediately. After a few hours of bed rest, your nurse will tell you when you may walk. Once you go home, following your cardiac catheterization, have someone stay with you overnight. Check your groin or arm every few hours for bruising, bleeding, or swelling. Take your medications and eat as you normally would. Avoid driving for 24 hours after your catheterization. Physical exertion and straining with bowel movements. Heavy lifting, which includes lifting grocery bags, weights, and children. When to call 911. Sudden bleeding that soaks through your clothes, apply pressure. Sudden swelling at the puncture site, apply pressure. Changes in your speech or eyesight. Chest pain that continues after following the steps you normally do when you have angina, for example, using your nitro spray. Go to the nearest emergency department with bad pain at your puncture site or weakness, numbness, coolness, or pain in your arm or leg. Call your doctor. Skin rash might be caused by your medication or a dye reaction.
Thank you and good luck on your road to recovery.